So let's go to the next MCQ. So 7 more. Okay, so long stem MCQ alert. Okay, so you review your patient who was a 36-year-old female patient who was recently diagnosed with multiple sclerosis, and she has a fraternal twin. Okay, so she has a non-identical twin who is a brother and accompanies her during this consultation, and he seems to be pretty concerned regarding his risk of developing multiple sclerosis in the future. So what would you tell him regarding his risk of developing multiple sclerosis in the future? And these are the questions. This is a frequently asked question, especially for those who are attending NESS. So actually, I've come across this scenario in real life. So actually, I had two identical twins who had presented with multiple sclerosis, but however, both of them had presented at different points of time. But however, both had presented with transverse myelitis. Both of them are doing well. They're actually on fingolimod. So, but this question is not identical twins. This question is fraternal twins, that is non-identical twins. Okay, I'll keep the chat box open for another 10 seconds. Sorry, I keep the poll open for another 10 seconds. Okay, so Sehaj as usual has got the answer right. Great, okay. So we'll end the poll. Most 50% and plus have got it right. So the answer is 1 in 15. So 1 in 13 is actually for identical twins. That is almost, that is 33%. Okay, so this I've actually seen both patients, identical twins, presenting with multiple sclerosis. So it's not that it doesn't happen. We've seen it. 1 in 15 is for fraternal twins. Okay, it's for non-identical twins. And 1 in 50, this will come to. Maybe I'll keep a tabular column. It'll be easier for you guys. So 1 in 3 is for identical twins. 1 in 15, that is in our MCQ, is for fraternal twins or non-identical twins. 1 in 25 is for any other normal sibling. Okay, and 1 in 50 is for half siblings. Okay, is for half siblings as well as parents. Whereas first cousin is 1 in 1,000, and the normal risk is 1 in 1,000. If so, just remember this. Okay, important, frequently asked question. It's there in Harrison. Please revise it. It's a totally factual question. Either you remember it or you don't. So those preparing for NESS, this is an important MCQ. So long stem question alert. So please pay attention. Okay. Right. Okay. So question number 24. So a 24-year-old female patient has presented to you with a right-sided optic neuritis, and you have treated her with a course of steroids, after which she has improved. And on examination, you note that there is a right-sided visual acuity of 6/9, that it is decreased, and there is a grade 1 RAPD in the right eye. And however, you do a detailed neurological exam, and you find out that she's having some spasticity over the left lower limb with the left-sided extensor plantar. So which of the following is needed to diagnose this case as multiple sclerosis based on the McDonald's criteria? Okay, so basically you have a patient who has presented with we'll come to the options. I just want to, we'll put it in the next page. Okay, so you have a patient who has presented with one clinical attack. Okay, you have a patient who has presented with one clinical attack. Patient has presented with one clinical attack, that is an optic neuritis. She has no history of any previous clinical attacks, but however, you have objective evidence. Of 2 lesions. Okay, you have objective evidence of 2 lesions. That is, you have a right-sided RAPD and you also have a left lower limb spasticity. So which of the following is needed to diagnose this patient as multiple sclerosis at this juncture? So little difficult MCQ. We'll see how many get it right. We'll come back to this MCQ after discussing the McDonald's criteria, so we can answer it again then. Okay, only 10 have answered, please. More of you need to try. Okay, guys, we'll conclude. It's a difficult MCQ, I agree. So we need to work on this. We'll spend a little time on this MCQ. Okay. So for that, we'll go into McDonald's criteria. So McDonald's criteria 2017 revised. This is the table given in Harrison. There are a few changes to it, which I will tell you. So now let's say the patient is having 2 or more attacks. Okay, the patient is having 2 or more attacks. Let's say the patient is having an optic neuritis and he's having a myelitis. Okay, so he's having 2 or more attacks, and there is objective clinical evidence for 2 or more lesions. Okay, so you have clinical evidence of 2 or more lesions. So what is this evidence? Okay, so this evidence can either be clinical. So clinical evidence could be something like an RAPD or a spasticity or an extensor plantar or an area of sensory loss. So you basically have history of 2 attacks. So the patient has a history of optic neuritis and history of and transverse myelitis, but that is not enough. You need to objectively provide the clinical evidence for this. Okay. And if you have 2 or more attacks with objective clinical evidence of 2 or more lesions, you can straight away diagnose the patient as multiple sclerosis. In the true sense, you actually don't need an MRI, even though that's not what we will actually do in the real sense. But in the true sense, if you have 2 or more attacks with objective clinical evidence of 2 or more lesions, yes, patient is diagnosed with multiple sclerosis. So objective evidence can be provided by clinical features. So a basic clinical exam is important, and evoked potentials. Okay. So evoked potentials is very, very important. So VEP, somatosensory evoked potentials. Okay. So VEP is visually evoked potentials. So this is the importance of evoked potentials in a patient with multiple sclerosis. So let's say the patient has an optic neuritis and a myelitis. Okay. And you check the patient, and however, your clinical examination of the optic nerve clinically is normal, but for myelitis, you are having some sort of clinical evidence in the form of spasticity or some upgoing plantars. But you don't have any proof for the optic neuritis. The fundus is normal. So in this scenario, doing a VEP is important. So VEP will show prolonged P100 latency. Okay. I'm not going to the details of this. Okay. Those who are preparing for NEET SS can go into this, but just remember, VEP will show prolonged P100 latency. So this gives us a new objective clinical evidence. Okay, so this is how you have to acquire it. So 2 or more attacks with objective clinical evidence of 2 or more lesions, yes, diagnosed. Now let's say the patient has 2 or more attacks, but has only objective evidence of 1 lesion, but with a reasonable historical evidence of a prior attack. Okay, the patient should have a reasonable historical evidence of a prior attack. That time you can diagnose a patient as multiple sclerosis. So let's go to the other scenario. So let's say you have a patient who has 2 or more attacks. Okay, but you have only objective clinical evidence of 1 lesion. So let's say the example again, patient has an optic neuritis, so that's 1 attack, and patient is having a myelitis. So you do have 2 or more attacks, but you have only objective clinical evidence for 1. So let's say you just have a prolonged VEP, but you have no evidence for this myelitis. Okay. So in this scenario, you have to establish dissemination in space. So in patients with 2 or more attacks, with only one lesion where you have an objective clinical evidence, you need to establish dissemination in space. So how do you establish dissemination in space? You should have 1 or more T2 lesions in the MRI in 2 out of the 4 MS typical areas. So I've already told you what are the 4 typical MS areas. It is periventricular, juxtacortical, and cortical. Okay, remember in Harrison, they have not mentioned it, but it is there in the 2017 revision. So both juxtacortical and cortical involvement, infratentorial and spinal cord. So in these 4 areas, you should have at least 2 areas should be involved with 1 or more T2 hyperintense lesions in the MRI. So either you could do this or you could wait for another clinical attack. Okay. So this is how you establish dissemination in space. So this is for this scenario. Now let's go to scenario number 3. And this is the scenario for our patient. So the patient is having only 1 attack. Okay. The patient is first time presenting to you with only 1 attack, but you have clinical evidence of 2 or more lesions. Okay. So basically, let's say the patient is present to you. Let's take our case. Okay. So she's presenting to us with optic neuritis. Okay. So she is present to us only with optic neuritis, only 1 attack. But on a clinical exam, she is having an RAPD and a decreased visual acuity in the affected eye. And she's also having some UMN signs in the left lower limb. So she is having objective evidence of 2 or more lesions. Okay. So in this scenario, you need to demonstrate dissemination in time. Okay, guys, this takes some time. I recommend after this class, you go back to Harrison and go through the tabular column. It takes some time to understand McDonald's criteria. For some reason, it's very difficult. And only after entering DM residency around 6 months, I was able to get the hang of this. So anyways, this is our case. Okay, so basically 1 attack with objective clinical evidence of 2 or more. So how do you prove dissemination in time? Okay, so the simultaneous presence of both gadolinium enhancing and non-enhancing lesions, which are asymptomatic. Okay, so simultaneous presence of asymptomatic, both enhancing and non-enhancing lesions in the MRI, number 1. Or number 2, if you already have a baseline MRI and this patient is presenting this time with a new T2 hyperintense or contrast enhancing lesion, irrespective of his timing, this is also taken as evidence of dissemination in time. And what is not mentioned in Harrison and very, 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 very important is CSF oligoclonal blast. So most of you must be wondering, why the hell do we do the CSF OCBs? What is the use? It's not to diagnose MS, but actually CSF OCBs is actually dissemination in time. Okay. CSF OCBs positivity is a proxy for dissemination in time. So how do you demonstrate dissemination in space? I've already told you in these 4 areas, at least 2 areas should be involved. And for dissemination in time, if you have a baseline MRI, and in this attack, the patient is having a new lesion, that is dissemination in time. If the patient is having asymptomatic, both enhancing as well as non-enhancing lesions in the MRI, that is also dissemination in time. And very, very important, presence of CSF oligoclonal band positivity is dissemination in time. This is based on the 2017 revision. For some reason, it's not mentioned in Harrison. I'm not sure why, but it doesn't mean it's not there. So please don't forget, CSF OCBs is equal to dissemination in time. So let's go to another scenario. So the patient has only one attack, okay? And you have objective clinical evidence of only one lesion. So let's say the patient has only optic neuritis, and objective evidence, you're only having some, let's say VEP is prolonged, okay? Let's take VEP is prolonged. P100 latency is prolonged. So you have one attack and objective evidence for only one lesion. And this is what is known as a clinically isolated syndrome, CIS, okay? In SS people, don't forget, CIS is very important. One clinical attack with one objective evidence, okay? So let's say an optic neuritis is only with a prolonged VEP. So in this scenario, you need to demonstrate both dissemination in space as well as dissemination in time, okay? So you need a DIT plus a DIS. I'm not going to repeat again. All of you know what is dissemination in time, and all of you know what is dissemination in space. So I'm not going to go into that. Okay, so that's a large MCQ. I think let's rush through the last 5 MCQs very soon. So which of the following correctly describes black holes in MRI and multiple sclerosis? Please open the polls. Okay. More of you need to answer, please. Okay, many are getting it wrong. I don't know why. So it's a rank deciding MCQ probably. Okay, I'm going to stop the poll anytime now. Okay, so most of you have actually ticked B. Okay, I'm not sure why, but just remember, black holes is nothing but in T2 weighted MRI, it will appear hyper intense. Most of the demyelinating lesions actually for that factor hyper intense on T2 weighted MRI, but on T2 weighted MRI, it will be hypo intense. Okay, but always remember, in an acute demyelination, all acute demyelinations will be T2 hyperintense and T1 hypointense. So this actually black hole should be analyzed in a patient who is neurologically quiescent, like not in an acute attack. So in those patients, when you take an MRI, if there is T2 hyperintensity with a T1 hypointense lesion, that is what is known as a black hole, and black hole means irreversible damage. Okay, it's usually a poor radiological marker. So it is T2 hyperintense, T1 hypointense, and it is a marker of irreversible demyelination and axonal loss. Okay, it is a marker of irreversible demyelination and axonal loss. And like I told you, it depends on the timing of image acquisition. There's no point of commenting on a black hole in an acute demyelination. All acute demyelinations will be T2 hyper and T1 hypo. But in a patient who is not an acute attack, if you take an MRI, and if you see many of the T2 hyperintense lesions on the MRI are actually T1 hypointense, that is not good. That is a black hole, and it's a radiological marker for a guarded neurological prognosis. So question 26, Paka factual question. So which of the following formulas correctly describes the CSF IgG index? Okay, guys, purely factual question. So I want you guys to again, guys, I'm just repeating again. These are actually somewhat basic. It's based on Harrison. For those who want a more detailed reading in neurology, or those who are preparing for the Central Institute exams, you can probably subscribe to the QBank. I've made, I think, around 1,400 MCQs for neurology based on Harrison and Bradley, and also my notes. So I think around 120 plus notes. I don't know whether it'll be I wouldn't recommend you to go through all of it for NEET. So NEET, just stick to medicine. For those for NEET SS, it will surely be useful. Okay, we'll conclude, guys. So I'll write down the formula. Okay. So first we'll go through what Harrison is given. So CSF IgG index is actually the ratio of IgG to albumin, the CSF divided by the same ratio in serum. So complicated words, let's make it simple. So basically CSF IgG divided by CSF albumin into serum albumin divided by serum IgG. Basically just inverted, guys. So CSF IgG index. So that's what you're looking for, no? So first what you do is you put CSF IgG divided by CSF albumin, and then you just multiply it into the inversion in the serum. That is serum albumin divided by serum IgG. So what's the answer? Yes. So it is CSF. That's what I think because of this a little complicated. So it's CSF IgG into serum albumin. Yes. Divided by CSF albumin into serum IgG. Yes. CSF. Okay. So factual question. Okay. So chat box. So to those who are active in the chat box, frequently asked question. So what is this sign? So can anyone tell me what is the sequence? I want you guys to tell me both the MRI sequence as well as what is the sign. Very, very frequently asked MCQ, not only in NEET SS, but also NEET PG. And I think it was first asked in November 2011 AIMS. That's the first time when they brought up this MCQ. AIMS PG, not SS. Yeah. So like I said, all of you are very, very well acquainted to this radiological sign. But I want you guys to tell me what is the sequence. Anyone wants to try? So that's more important, especially for those prospective neurology residents. So say I just put as, yeah, Sapna got it right. It is T2 flare. Okay, great. So T2 flare, what view? Sagittal. Okay, great, Sandhya. So sagittal. Great. Okay, so this is a T2 flare, MRI brain. Okay, always go from MRI brain. And this is a sagittal cut. And this sign is seen only in the sagittal view. So that's why I wanted to ask you what is the sign. So this is basically periventricular. You can see these finger-like projections, T2 flare hyperintense finger-like projections. So this is known as, oops, sorry. So this is known as Dawson's fingers. Okay, so this is known as Dawson's fingers. Very, very frequently asked question, not only for NEET SS, for NEET PG also. So you can't afford to get it wrong. So that's why I put it. And the reason for this Dawson's fingers, so nice to know, actually it is because of the perivenular. Okay, so you have these medullary veins in this orientation, which are radially oriented. So for some reason, most likely because of the fact that the immune cells are actually near the blood vessels. So because of this perivenular demyelination, and these vessels or veins are actually oriented radially. If you take the perimedullary veins, are actually oriented radially. So around these veins, you have this demyelination. Okay, so that is the reason why you get Dawson's fingers. Just a nice fact to know. That's it. So question number 28, again, factual question, guys. So which of the following is false regarding pregnancy and multiple sclerosis? Please open the polls. So overall disease course is unaffected, more attacks in the first trimester, less attacks in the third trimester, and more attacks in the postpartum period. Purely factual question. It's an all-in-one phenomenon. Either you know it or don't. So if you don't, it's okay. I'll tell you right now. Most of you are getting it right. Remember, the question is what is false, not what is true. Okay, guys, we'll conclude since most of you have got it right. Okay, so let's analyze this MCQ. So we'll go from down to bottom. Okay, the reason I'm going down to bottom is because A is actually the answer. Okay, so more attacks in the postpartum period. Yes, this is the correct answer. Less attacks in the third trimester. Less attacks in the third trimester. Yes, this is the correct option. Overall disease course is unaffected. Yes. So if you take the pregnancy as a whole, including the postpartum period, so even though there are less attacks in the third trimester and more in the postpartum, this evens it out. So overall the disease course is unaffected. More attacks in the first trimester is a false. Okay, so this is the answer. It is not such. It is not like that. There are no more attacks in the first trimester. There are just less attacks in the third trimester, but there are more attacks are in the postpartum period. But overall, disease course is unaffected. So course of MS in pregnancy, third trimester, more attacks. Postpartum, sorry, my bad, mistake. Third trimester, there is less attacks. Postpartum period, there is more attacks. But overall, it's the same. All right, so we'll go to the next MCQ. So question number 29. So what is the Kurtz's EDSS usually in patients with progressive multiple sclerosis? So EDSS is basically a scoring system that helps us to understand the disability of our patients with multiple sclerosis. It's a very important scoring tool for most of the trials, the drug trials that are done for multiple sclerosis. So it's very important for us too. It is an MCQ. Okay, so I think 31% have given it wrong. For some reason, 62% have given the answer as B. Okay, so the actual answer is actually not B. The answer is actually 4. Okay, so an EDSS of more than 4 is usually seen in the progressive varieties of multiple sclerosis. This is taken verbatim from Harrison. So your SPMS, that is secondary progressive MS, as well as PPMS, primary progressive MS, both generally tend to be neurologically doing much bad than their RRMS counterparts, and usually they have an EDSS score of more than 4. So the Kurtzky EDSS is a widely used measure for the neurological impairment in MS, and usually the RRMS patients will have a score of less than 3.5, and usually these patients are ambulant. Okay, they can walk normally without any sort of support, but in contrast, in patients who have EDSS scores of more than 4, so this is an important point in the EDSS. So more than 4, usually the patients are significantly gait impaired, they're occupationally impaired, usually need support, some sort of crutches or sticks or wheelchair to ambulate, and this is usually seen in the progressive varieties of MS, that is SPMS as well as PPMS. So I just wanted to show you the EDSS. Okay, so you can't, it's very difficult to by heart it. So just remember that 0 is normal neurological status and 10 is actually death due to MS. Okay, 10 is death due to MS, and here we can see the cutoff at 4. Okay, so usually see at 3.5 EDSS, the patient is fully ambulatory, but only with moderate disability in one of the functional scales. But however, once the patient reaches the EDSS of 4, the patient needs support to walk. Okay, so that this 4 cutoff is very important. Usually less than 4, relapsing remitting MS, somewhat neurologically better. More 4 and above, they're usually significantly neurologically impaired, especially in ambulation. So how do we calculate this EDSS? Again, I'm not going into the details. It is out of scope from this class. So just remember what are the different domains that are assessed in the functional status score for putting EDSS. So one is pyramidal functions, cerebellar functions, brainstem functions, sensory functions, bowel and bladder functions, visual functions, and very, very important, we tend to neglect is cerebral or mental functions. So most of us have the norm that multiple sclerosis patients usually just have some weakness, optic neuritis, have some bowel and bladder issues. But actually that's not true. Many of the multiple sclerosis patients have cognitive issues and sometimes are significantly cognitively challenged. That's also very important. It's not that MS spares the cognition. Okay, that's a very common feature in MS. So I conclude the class with this. So I think I've covered most of the important topics. Okay, so it's very difficult to cover entire multiple sclerosis in one class. It's a very vast topic, but I just wanted to touch upon the important things like McDonald's criteria, the 2007 update, and OCB positivity for dissemination in time, and presence of cortical and juxtacortical lesions, and the other important facts. So we'll conclude. We'll cover treatment of multiple sclerosis. It's a very huge topic. Okay, it's not possible to cover it in one class. So probably I'll gel the multiple sclerosis treatment with one of the other classes. So if you guys want to get back to me, or if you have any other doubts, or any of you want to pursue neurology as a career, who are prospective neurology residents, you can follow me on Instagram. I will try my best to personally address your doubts or whatever. And yeah, and I also need your feedback for the class so I can improve. So it's very important to keep improving. And I think I'll stop. And with this, it means a lot. Okay, thanks.